So today I wanted to talk about retinal detachment. This is another common condition that lots of people present to the clinic with. But there are different types of retinal detachments, and sometimes the management and the treatment of them can be very different. So it's important to cover that and to explain the rationale for why we do what we do. So first of all, who gets retinal detachment? Well, there are certain risk factors for developing the condition. Some of these, you hear about and are quite widely known, such as trauma, for example. Boxing is associated with a higher incidence of retinal detachment. Um, but actually, the most common reason for a detachment is just the aging changes in the jelly of the eye, in the vitreous humor, as happens in all of us. Now, when the jelly gets older in the eye, the jelly shrinks, and as it shrinks, it starts to pull on the retina, which is the wallpaper inside. And most often, the jelly just comes away from the retina, pulls off with no consequences. Occasionally, it can get snagged on a blood vessel, in which case you can get a bleed in the eye, a vitreous hemorrhage. Occasionally, it can get trapped and get stuck to the retina itself and pull a retinal tear as the detachment of the jelly progresses. And if you get a retinal tear in the retina, that is the most common reason for developing a retinal detachment, as the fluid from inside the eye comes in through the tear and the retina starts to peel off. Now, this is a relative emergency because if we don't intervene while the detachment is small, if the central part of the retina has time to detach, then unfortunately it gets damaged. And so your vision is going to be permanently affected. Because what happens is when the retina detaches, it stretches. And when it stretches, all the little photoreceptor cells in it, all the pixel cells, they spread out. And then when you reattach the retina with an operation, it sits back down, goes down nicely, sticks down, but it remains a bit stretched. And so you get some permanent distortion in the vision, things looking bent out of shape, and usually objects appearing smaller because of the retinal stretch. And that's what we're trying to stop, because if we catch a detachment early, when it's just affecting the edge of the retina, then we can prevent that permanent visual effect. Now, what increases the risk of developing one of these detachments? Well, trauma, injuries is one of them, but actually that's a rarer cause. Being short-sighted is the main risk factor, because a short-sighted eye, so a myopic eye, is larger than average. And the retina inside is stretched thinner to cover that larger area. And so the thinner retina is more likely to tear when you get these age-related changes in the vitreous jelly. Genetics plays a part as well. So if you've got a family history of retinal detachment, that might mean that you're at higher risk also. There are other types of retinal detachment. So there is another type of detachment which often people aren't aware they have. So these are typically young patients, children, people in their teens, 20s, maybe 30s, who usually have an incidental finding of a detachment. For example, they go to the optician has a look and goes, "Oh my goodness, you have a detachment. This is an emergency. You must go to the eye emergency department." And they come to us and we sort of run around and then we say, "Actually, no, you don't need anything doing straight away." And then this creates a lot of anxiety, understandably. But actually, what happens is, especially in short-sighted eyes, but in sort of people who don't wear glasses occasionally also, you get little round holes in the edge of the retina. And these round holes are just little defects where the retina didn't form properly or got stretched. Um, and in the majority of people, these little round holes, they sit there all your life and they do nothing. They do have a slightly increased risk of retinal detachment. It's estimated to be around 5%. Just if the edges of the hole do lift and allow some fluid from inside the eye to come underneath them. But actually, if that detachment hasn't happened in your early life, it's very unlikely to happen going forward. And you're more likely to get the sort of detachment risk later on when you get the age-related jelly changes. So these little round holes, when we see them in a normal retina without a detachment, some people will do some prophylactic laser treatment to reduce the risk of retinal detachment, just to seal the retina around the hole. But most of us will actually do nothing because doing laser has a few risks, and doing nothing the risk of developing a detachment from these round holes is very, very small. But if we do find one of these detachments that has happened, often the person's not aware of it. And it's quite common for us to see signs that tell us that the detachment has been there a long time. If it has been there a long time, there's some scarring we can see, and it tells us that it's not gotten any bigger recently. And if that's the case, then actually sometimes we will observe it. We don't need to do an operation every time. We don't need to treat it every time. We might just watch it. And then if we notice that the detachment's getting bigger over time, that might be an indication to operate. Occasionally, other times, we might offer some laser treatment to seal the edge of the detachment and reduce the risk of it getting larger. And other times still, if the patient feels strongly that they want the detachment gone, or if we feel that it is getting bigger, or perhaps it is more recent, more fresh rather than long-standing, we may discuss and offer surgery, which can definitively fix the detachment, but does carry a few surgical risks. So that's the conversation we have with retinal detachment patients. And if you've been diagnosed with one, it's important to establish which type you have, all the management options available, and have a good discussion with your surgeon regarding the best one in your case.